Good afternoon, and welcome to the Ask the Docs, a Fertility Institute of Hawaii live stream. This month, our topic is what happens in the andrology and embryology laboratory. This was chosen because July 5th is World Embryologist Day. Thank you for joining us. We have a lot of great information to share with you. My name is Dr. John Fratarelli. I'm here with Drs. Anat Carmon and Dr. Emily Goulet, and our special guest, Pauline Garrison. Pauline is our senior embryologist and technical supervisor of the IVF laboratory here at the Fertility Institute of Hawaii. I guess we'll start off by just saying, maybe Dr. Carmon, you can tell us what I just said when at World Embryologist Day, but what is it?
What is embryology?
What is World Embryologist? So I guess why is it important? Other than we do IVF, what else is important about it?
Well, I think that what's important about World Embryology Day is that we're recognizing embryologists who are they're kind of like the elves in during Christmas. I don't know. I'm Jewish, so I don't know a lot about this, but my understanding is that Santa Claus has elves, and they do all the kind of behind the scenes work, even though Santa Claus gets all the glory. So although as physicians, we're the ones who are often consulting with you as patients, we're the ones who are typically doing the procedures on patients. It's actually the embryologists who are working with all your eggs, your sperm, who are putting the eggs and sperm together, who are freezing eggs, freezing embryos, and preparing for our procedures like embryo transfers. They're also checking on the embryos at certain times throughout the cycle and evaluating the quality of the embryos. And so without them, we really couldn't function at all as a fertility center. In addition to that, they also work very, very closely together in the lab, and they are the ones who really oftentimes determine our success rates, to be honest with you. And although I like to think that, I'm the one who's making the magic happen, it's actually usually Pauline behind me who's going to determine whether or not you get pregnant.
No pressure.
So I think that recognizing embryologists on World Embryology Day is very important because we kind of don't, I think, recognize them enough on other days. So they get like a day or a week or whatever it is for us to talk about.
And July 25th is
the answer you were looking for. I wasn't sure where you were going with that.
Yeah. So July 25th is actually chosen because that's the date of Louise Brown's birthday. She was the first IVF baby born in 1978.
That's the answer you were looking for.
Yeah, that's okay. I didn't give you a multiple choice question. You have to read my mind.
Happy birthday.
So Louise Brown born in
so
1978, first IVF baby.
Like the questions you ask, I never know what you're talking about.
I'm sorry. Maybe we can ask Pauline, since she's here, how the laboratory personnel are organized and what happens in the lab. And I guess before you even do that, why don't you kind of introduce yourself? Tell us your background and when you started doing IVF and everything.
So my name is Pauline. I'm a senior embryologist here. I've been here since 2018. I started in IVF in 2003, so I've been in this field quite a long time. I started back in DC, and I worked there for 4 years, and I came to Hawaii in 2007. I worked at another clinic for many years, and then kind of was looking for a change of pace, so I came here. So I've been in this field for quite a long time. I've seen a lot of things change, going from slow freezing to vitrification, not a lot of egg freezing at all to egg freezing, no PGT, that wasn't a thing back then, to doing day 3 biopsies on all the embryos to just doing blast biopsies. So I've kind of seen a whole lot of things.
Excellent. And how is the like talk us through, who's in the embryology lab and what everybody's function is.
So you want like names or?
No, just like how many senior embryologists, just numbers.
So we have, right now we have 7 embryologists, kind of different levels of what they're able to do. Everyone's always on their own training program. So we always have people learning different things. We have 2 seniors right now. We have, I guess 4 seniors right now. And then some juniors, and then some people that are still kind of just started with us. We also have andrology, which we run also our endocrine lab through there. So we have another 4 people there. So yeah, we've got quite a full staff, but everybody, we do a great job of making sure everybody gets rest. And, that's why we keep the staff a little bit higher for that reason.
And I think it's important to realize too that unlike family practice office, OBGYN office, and any other office, a fertility office, a reproductive infertility office requires so many people behind the scenes in the lab and doing other things that patients really come in very little contact with and know little about to get everything done. And I think that people are always very surprised when they hear that we have 60 plus staff, because that's unlike most physician practices other than fertility clinics.
And we're also here every day too, as long as there's embryos. So even if you think, they're closed Saturday, Sunday because there's no procedures, as long as there are embryos in the lab, somebody's going to be here checking them, changing media, doing a biopsy sometimes on day 5, day 6, day 7. So there's always something going on here.
So Pauline, can you walk us through the life of an embryologist? Like a day in the life of a senior embryologist. What are you doing?
So just like a typical day in the lab, basically.
Yeah.
So we usually start around 7, and the beginning is somebody always starts QC. So QC is quality control. So we're always checking all of our equipment, making sure everything's running at the right temperature, our liquid nitrogen tanks. Everything's connected to sensors. So if anything would run outside of the values that we want them to be, we would be alerted overnight. So we can always come in and fix the situation. Nobody's ever going to come in with surprises in the morning. But that QC is important because we'll be able to catch trends before anything falls outside of that and those sensors start going off. So that's kind of, even though we have an alarm, we don't just let the alarm do the work for us. We're always trying to monitor to make sure everything's working well before it gets to that state. So morning we'll be prepping for the procedures that we have that day, warming any media that we need to warm up. If we have frozen embryo transfers, it would be collecting those embryos from the liquid nitrogen tanks and starting to thaw those so that they're ready for the late morning transfers. We'll also be doing FERT checks in the morning, so checking the fertilization from the retrievals the day before, seeing which embryos fertilized, sorting them out in the dishes. We do media changes on day 3, so that would happen also in the morning. And then kind of after those, so fertilization is time sensitive. We have to get that between 16 and 20 hours after retrieval. So after that, we just start doing the checks for the day. So that would be anything that we're going to freeze or biopsy on day 5, day 6, day 7, sorting those embryos out and then starting to freeze them or biopsy them. And then we usually do ICSI about 4 hours after retrieval. So that's kind of the late morning, starts the ICSI, and we'll be doing transfers around that time. And then the rest of the day would just be prepping for the next day. So getting paperwork ready, getting dishes ready for the next day. That's kind of a typical day for us.
So it's a lot that goes into your typical day.
Yeah.
And how is the typical day now different than it was in 2003, 4, 5 when you started?
Yeah. So, oh gosh. Yeah. So, yeah, things were different back then. I feel like the stimulation was a lot higher. I feel like we used to get a lot more eggs. Everybody was kind of pushing to stimulate higher back before we knew, stimulation protocols could be a little bit varied. We would do a lot of, I guess when we started doing biopsies, we were doing biopsy on everything on day 3, thinking that, oh, once you knew what the chromosome analysis was on one, so on day 3, we only take out one cell. It turns out that having one cell isn't necessarily representative of the embryo, which we found out later. So that's sort of why things have progressed to doing blastocyst biopsies. We also did not do blast freezing and thawing. So we would typically freeze in vials of 3 to 5 embryos per vial, and that was a normal thing to transfer that many embryos back then because we were only doing day 3 transfers. And again, when you're transferring, we were getting a lot of multiples at that time too, which is great how we moved to the blastocyst culture and single embryo transfers. That helped with the multiple rates a lot. So yeah, things have gotten a little bit different. We did slow freezing too, which was a machine that took 2 hours to do your slow freeze. It was a machine that would just take a certain amount of degrees down every minute. So it would take a long time. You would load all of your embryos into this machine and you would wait for the machine to be done. Now we're doing vitrification, which you just take the embryos through media and you just plunge them into the liquid nitrogen. So it's a lot faster to freeze these days than it was back then. Yeah,
that's sounds so easy, but it's not just something you can walk into a lab to and pick up in a day or two. It's something that takes years and years of experience in order to get very good at it.
Yeah, it does take time.
So what about, maybe we can go through a little bit some of the really important steps that we always update patients about. So maybe you can tell us a little bit about what are you looking for when, maybe you can go over the fertilization process. Maybe you can go over when you first get those eggs, if we're doing ICSI or conventional insemination, kind of just describe what we're doing there.
Sure. So when we retrieve eggs, they come out of the follicles with a bunch of cells around them. They're called the cumulus cells. So if we're doing ICSI, we're going to strip those cells away from the egg, and then we'll just have the egg by itself. Once we have those eggs, we can assess the maturity. So what we're looking for is a polar body. It's just a little piece that's outside of the egg. When we see those, then that's how many we have mature. We can only inject the ones that are mature. So if you have, for example, a cohort of 20 eggs, sometimes we see cases where we only have 5 mature. And unfortunately, we can only inseminate those 5. With conventional IVF, we won't strip away those cumulus cells. We'll leave them. Those cumulus cells actually help the sperm find the egg, and it helps with the fertilization process. So in those cases, we'll just retrieve the eggs, put them in a dish, mix them with the sperm, and then check fertilization the next day. So like I said, when we check FER, it's 16 to 20 hours after the insemination. What we're looking for is 2 pronuclei. So it's basically the nucleus from the mom's egg and the sperm. And that's what we're just trying to analyze. We'll take out anything that looks like it's abnormal. We'll hold on to anything that looks like it didn't fertilize, because sometimes we just miss that window. Sometimes eggs go a little bit faster, sometimes slower. So we hold on to everything and just watch for the cleavage. And sometimes those 0 PNs, which you don't see any pronuclei, they do make blasts. We just sometimes miss the window.
And then I guess maybe I'll ask Dr. Goulet, doing freeze-all cycles versus doing fresh cycles, because Pauline mentioned earlier that in the past, we were doing a lot of day 3 transfers and even day 5 transfers when we started doing blast, growing embryos to blast and culture. And now we've gone to basically freeze all cycles and delayed embryo transfers. I wonder if you might want to just explain to the listeners, the patients, about why that transition has happened.
Yeah, well, there's various factors that have lent to it, but basically the bottom line has showed us doing frozen transfers, we see higher pregnancy rates. And there are several things that are contributing to that. One is with the stimulation where we do an egg retrieval, we're really boosting hormone levels up to supraphysiologic levels. And The uterus often cooperates, but not always. And when we find if we let a woman have a period after her stimulation and instead give her a different set of medications really meant to optimize the lining of the uterus, we're able to get the hormones and the uterine lining more where we want it to really increase the rates of implantation. So for that reason, we do favor frozen transfer. And the other benefit of a frozen transfer is that timeline, that gap of waiting for a period and giving that second round of medications buys us some time where we can now genetically test our embryos. And that also boosts our implantation rates quite a bit. And I think our embryologists are just fabulous. I make the comparison that, we are all awesome surgeons, but our embryologists are microscopic surgeons because they're the first ones from the stripping of the eggs to the ICSI of the eggs to the biopsy. All of those are microsurgical techniques. They're doing all of this underneath the microscope.
And maybe Dr. Carmona, for patients that are wanting to look at an embryo, and I guess when patients undergo IVF, a lot of times what happens is, they have a certain number of eggs and then a certain number fertilized and then a certain number, there's always an attrition rate. I wonder if you can explain maybe how that process happens if someone has, 20 eggs retrieved, how many embryos they might expect at the end and why they get that, that decrease in number along the way.
Right. So this is always a really interesting thing to grasp and grapple with. But IVF really is oftentimes we see a reverse pyramid, unfortunately, right? So like what Dr. Grattarelli was saying, we have some number of eggs that we retrieve initially, and then usually, not always, I suppose, because we're talking about probabilities here, but usually we're going to see fewer number of embryos. The number of embryos that we're going to see towards the end of that kind of reverse pyramid is dependent on many factors: egg quality, sperm quality, essentially the quality of the embryo, of course, and patient age. We may see blast development rates 30 to 50%, but they could be higher, also based on the patient's diagnosis of infertility. For example, if we're doing in vitro fertilization because somebody has a tubal factor infertility, then we might see a higher number of embryos because they don't have an embryo issue. They have really an anatomic issue that we're correcting. But if there's a patient who has an egg quality issue or perhaps a severe male factor problem, then potentially we may see fewer embryos towards the end of that road. But it is also important to note that not all embryos are meant to be in human reproduction. Okay, so the typical fecundity rate, I feel like a deja vu, like I kind of talked about this in a previous Facebook Live, but the typical rate of pregnancy in two people who are having unprotected intercourse and they may be at their peak fertility in their 20s, their chance for getting pregnant every month is really only around 20% or so per try. So 80% of the time they're not going to get pregnant. Now, we still recommend using birth control if you're not trying to get pregnant. So that 20% per month really does add up. But interestingly, we are just very poor at reproduction versus, bunnies who don't really seem to have any problem at all. And that is normal. A lot of that does have to do with the high rate of aneuploidy in embryos, the high rate of genetic abnormalities or chromosomal issues in embryos. And in fact, weirdly enough, most embryos are abnormal, although most babies are normal. And that's what we see probably when we see a high number of eggs but a low number of embryos that continue to develop. The thought is that many of those embryos that didn't continue to grow kind of made some mistakes in division along the way and were abnormal and therefore really didn't make it to the end of that pyramid. Those embryos which made it to the end of that pyramid are potentially, hopefully, more likely to be normal, but they still may not be. Hence, there's still kind of a journey to get to that healthy baby at the end. And so I hope that that's the answer that you were going for, Dr. Frederelli. Very difficult.
Perfect.
Okay.
Yeah, there's a first time for everything. Yes.
Okay. I feel like you're like, I'm glad you were not my board examiner, because I would have literally no idea what you're talking about ever.
So I guess one of the questions I get that I struggle with, because I don't like the term, is what's the grade of my embryo? And they're really not grades. They're how you describe an embryo. They're the morphological description of the procedure or of the embryo, or how embryologists talk to each other to know that this is what the embryo looks like. So if someone says it's a 3BB, then Pauline knows exactly what that embryo looks like, right? But that doesn't mean a whole lot, or doesn't mean much as far as what that embryo is capable of, because as you were just saying, a lot of those embryos are going to be chromosomally abnormal. But I guess where I'm going with this is, Pauline, if you could kind of go through kind of what you look at when you're doing the embryo morphological score or grading.
Yeah, so so we're certified by the College of American Pathologists, and part of that is we do have to do proficiency testing, and one of them is actually embryo grading. So what they're trying to do is they're kind of trying to figure out that gray area, like you said, between labs, where we got to make sure that if they're calling it a 3BB, that we're calling it a 3BB, that the next lab is calling it a 3BB. And that's sort of, like you said, there is some subjectivity to it. If I look at it, it might be, I might think it's a BC and somebody might think it's a BB. So doing this proficiency testing helps us kind of make sure we're all reading it the same way. So they basically send us pictures, and we're supposed to grade it, submit our answers, and they kind of tally what we're grading compared to everybody else in the country that's part of it too. So it's a really great method that we can all make sure we're all on the same page. Internally, we do our own quality control for that. But this is sort of the benefit of having so many people in the lab, is we frequently say, I need a second opinion on this. Is this something that you would want to freeze? Is this something that you would want to biopsy? And I think a lot of patients don't realize also that these things are alive and they're constantly changing. So things that we grade in the morning, somebody can come back in the afternoon and say, boy, this looks a lot better. Look at this ICM that the inner cell mass of that embryo. They can say, wow, this was a B, but look how pretty it is now. It's so nice and compact. We really need to change the grading. And we do frequently change the grading. And it's not because somebody's made a mistake or an error. It's just they grow and they change, and there's cells that are, proliferating, and there's cells that are, degenerating too. So we kind of have to keep in mind that this will always change. Also, after the thawing too, we see a lot of embryos changing grade sometimes. We receive a lot of embryos from outside clinics that we're doing thaw biopsies on, that we're just doing frozen embryo transfers on. We typically regrade after the thaw too, because they do change grades. So it's not necessarily, it's this one thing and it's always going to be this one thing. They change and they grow and they shrink, and we're just, trying to give our best description of what it is that we see. And we try to all be on the same page about it. So we do talk about, what things look like a lot in the lab.
And I think
So
you
I have
made
a question for Dr. Frederelli, though, about that. So how do you, I'll try to ask like a riddle.
Yeah, let me figure it out.
You,
I'll figure out what you're saying. Yes.
Okay. So how well does the grade predict the outcome?
Not very well. It is predictive. An embryo that is a 4AA has a better chance of making a baby than a 4BB, but not a huge difference. Because when you do genetic testing on the embryo, chromosomal testing, if that 4AA is abnormal, well, then it's a 0% chance of making a baby, essentially. And if the 4BB is normal, it has a 70% chance. So then it's reversed. And we do see that sometimes, where the best looking embryo actually ends up being abnormal. And it's the ones that we thought looked a little less good that end up being the normal embryos that make a baby. And to Pauline's point, these embryos change. And so you look at an embryo at 10 o'clock, it's different, at 2 o'clock. And you want it to change. If it's changing, that means it's viable and it's moving, it's alive and it's moving along. And so you want that change. And so an embryo that you grade as 4BB later, if you watched it later on, it may have been a 5AA, which is a really good quality embryo, but because of when you looked at it and had to freeze it, you gave it a 4BB score at that time, because it's just one point in time that you're looking at that embryo. You're not really assessing it later on. So it does have some validity as far as ranking the embryos. What I also tell my patients is it's kind of like going to the horse races where you're trying to pick the best horse, the prettiest horse, the you think is going to be the fastest horse, and they're not always that, right? Sometimes it's the other one that is just kind of a so-so horse that's the one that's the winner every time. And embryos are kind of like that too, because they are dynamic and they change.
Okay.
I wonder.
So what do you guys think about? Should we talk more about genetic testing and what we're able to do with that? What kind of? You kind of mentioned the success rates a little bit, but maybe Pauline, you can just reiterate now what we're doing with pre-implantation genetic testing, and then we can kind of talk about what the success rates look like with that and when it's useful, when it's not.
Yeah, so like I said before, biopsies have come a long way from back when we first started doing this. We've learned a lot and the techniques have changed a lot. What we're doing now, like I said before, we used to just test 1 cell out of 8, so we weren't really getting, they were saying, it might be that you're pulling a cell out that's not really going to even be part of the embryo. So what are you, what's the information worth that you're getting? So I think that's why the first round of doing biopsies, when we were doing this back in the early 2000s, we weren't really getting the results that we wanted to get. But now that we're doing blastocyst biopsy, so we're waiting for the embryos to get advanced. They're already starting to differentiate. So you have basically a ball of cells on the outside, which will become part of the placenta, and inside you'll have the inner cell mass, which will become the baby. So we're taking a section that's outside, taking 3 to 5 cells of that, which the blastocysts handle very well. We don't have as much damage to the embryo as we used to when we were doing day 3 biopsies. So they're quite plastic in their ability to handle that kind of removing of those cells. We're taking those cells, we're putting them in tubes and sending them to the reference laboratories, which do the PGT testing for us. And the rest of the embryo will get frozen, and then we just wait for the results to come back. So.
And I might just add to that, initially when we were doing day 3 biopsies on blastomeres and just taking 1 or 2 of the blastomeres, out of 8, the thought was that those cells were totipotent, meaning that if you just separate all 8 cells, you get 8 embryos growing. And that we found wasn't exactly true all of the time, that these cells had started to differentiate. And so the subsequent studies did show that there was a little bit of a harm done to potentially to some embryos there. And so pregnancy rate and implantation rate was a little bit lower in some of those embryos that were biopsied on day 3. The other thing with the day 3 is that initially doing FISH testing, we were not able to look at all of the chromosomal complements. So all 22 pairs of autosomes plus the X and Y, or the 2 X's. So if you're going to count those as the 23rd pair. So you'd only be looking at 2, 3, 4, 5 chromosomes rather than all of the chromosomes. And so there's a lot of information that you didn't get. And then when we moved to trophectoderm biopsies, or on day 5 at the blastocyst stage, we found that by removing a few cells from the trophectoderm, that essentially does not harm the embryo at all. Because there have been very sophisticated studies looking at biopsying an embryo versus not biopsying an embryo, putting both of those embryos into a uterus, back when we were putting 2 in, and then seeing which one actually took. And finding out that the implantation rate was the exact same, regardless if you biopsy the embryo or didn't biopsy the embryo, and pregnancy rates were exactly the same. So So that's why at least what we have at this point seems to be the safest way to do it, and by far gives us the most information and is the best for the patient.
So all of us, I think, in general, we do a lot of PGT or pre-implantation genetic testing in our lab, and so certainly we're kind of PGT champions, I think. But not everybody, not every center is like that, and there are still, although less so, still some controversies about PGT and who it benefits, who it may not benefit. Dr. Frederelli, for those, if you were in a debate right now and you were playing the side of, PGT, sort of the anti-PGT side, what have been the arguments regarding PGT and why it may not be useful for everyone?
Well, there's certainly, just like anything, there can be a small amount of error involved. And so the testing is not 100% accurate. It's 99% accurate. So the accuracy is as high as we can get it right now. But I think the other thing that we always have to remember is no matter where we are right now, 10 years from now, we're going to look back and go, oh, we could have been doing that a lot better because we learned more. I mean, just like 10 years ago, we were doing FISH and looking at day 3 biopsies, now we think, oh gosh, we would never do that. But that was the only thing we had. And that was the best thing we had at that time. This is the best thing we have at this point. I think, for some patients, if they only have one embryo, it's very reasonable to do a transfer. There is certainly a slight risk if an embryo is not of sufficient quality that you don't want to biopsy it. And if it's not sufficient quality, you may not want to freeze and thaw it as well. There is a chance that an embryo is about a 3% chance that an embryo, when you thaw it, may not survive. So there is that loss potentially, even though it's small. And so that we always want to guard against that as well. I'll make a comment for one of our listeners who was asking, is there anything else that affects grading? The age of the patient really is huge. An embryo, a 42-year-old patient does not have the same, the embryos do not look the same as they do in a 22-year-old embryo. But that embryo still can make a baby. It's just the way it looks. Again, if it's chromosomally normal, it still has the chance of a chromosomally normal embryo that's 22 versus a chromosomally normal embryo that's 42 from a 42-year-old. The chance of those two embryos making a baby is essentially the same.
And then also to go back to PGT, and I also think that there's a very important point that sometimes gets lost here. But when we're doing PGT, we're not making the embryo normal or not normal. We're ultimately not changing the overall success rate of the cycle. We're changing we're maximizing the first try. Right. And so if you just have one embryo, you can test it, figure out if it's normal or not, or you can transfer it, but it's either normal or not. And so I think that's a very important point. Now, when you have lots of embryos, obviously you don't want to go through 6 transfers until, you find that 7th one, which is the normal one or something. It's nicer to kind of do that ahead of time, but ultimately you're not really changing that outcome in the end. You may prevent miscarriages. Many miscarriages occur because of chromosomal abnormalities. So by not transferring an abnormal embryo, you may be preventing that miscarriage. And you are preventing the potential cost and loss of time that's associated with a transfer, which is unsuccessful. It's less common that you're preventing the birth of an abnormal baby because most embryos which are abnormal are just not going to implant or end in an early miscarriage, although you can potentially also prevent the transfer of an embryo which could progress to live birth, which is abnormal. So pregnancy loss is definitely something that may be preventable through this in many cases. But I do want to point that out because I think that, there are other technologies that we have available which may actually change outcomes and change the outcome of the cycle. But PGT is a little bit different in that. That's what I wanted you to say, John. I'm
Oh,
sorry.
thank you. Thanks for letting me know now. I wonder, Pauline, if you could, some of the other things that I think everyone's concerned about is how do I know it's my sperm? How do I know it's my egg? How do I know it's my embryo? And I wonder if you can kind of talk us through what happens in the lab to ensure that.
Yeah, so again, one of the benefits of having, quite a larger staff is you always have somebody available to do a second ID. So we're constantly checking dishes with each other. So prior to the retrieval, the patients come in and they check their name. We flash the dish so everybody knows that that's the patient that we're doing the retrieval on. We also have somebody checking the dishes where the eggs are going to go into, so the retrieval matches up with those dishes. We have a second ID, so the person that's doing the insemination also has somebody else double checking the sperm and the egg dish and the ICSI dish to make sure all of that matches up. At the thaws, we have somebody else, whoever's doing the thaw is reading off the stick. The person has the paperwork, is double checking that. After the thaw is done, when they go to get the dish, the transfer dish, that is second checked. So there's constantly second checks. Same thing with andrology. When your sperm comes in, everything is second checked. So that's one thing that, we're very, very strict about double checking. So yeah, everything's constantly looked at by at least two sets of eyes.
I think it's also important to realize too that you're never, if you're doing ICSI, you're doing ICSI on one patient, not multiple patients. If you're doing a semen analysis or semen wash or preparing sperm, you're preparing one sample, one person's sperm. You don't have multiple samples that you're trying. A lot of us will multitask everything that we're doing. I'll be talking to a patient and trying to do it. Well, not talking to a patient, sorry, talking to Dr. Carmone and emailing at the same time and doing some other things. But in the lab, they can't do that. They have to, you have to be focused on that one patient. You can't have any other samples around because this is very serious. We can't have any chance of anything being the wrong specimen.
And that's also why we ask for some, this is my little plug here, right? When patients are like, well, why can't I cryo sperm on this day? Or can you please squeeze me in? And so, if it was sort of just a quick ultrasound or a quick appointment with me, I'd be like, oh yeah, sure, I can just squeeze you in. We'll just be quick. But with lab procedures, we can't do that. And so, we do ask our patients to be flexible and understanding with the fact that, it is much more difficult to squeeze people in for lab procedures like semen analysis or sperm cryo, things like that, than it would be for, simple appointments, consultations with me or something. Yeah.
Good point.
I feel like we've talked and covered a lot of things. I don't know if there's anything else that you guys feel we need to discuss at this point.
Pauline, did you have anything else that you?
Now, if you guys have any questions that you think comes up a lot from patients that you wanted to specifically ask the lab or anything like that, because I know sometimes the lab is like this shrouded in mystery place that nobody, and I know nobody wants to bother us because we're busy, but yeah, if anybody has any questions that are burning. Dr. Goulet, who always has questions that are burning.
Yes, well, and that's the wonderful thing about our embryology team is I can swing by anytime and ask them for some input or some feedback on how a patient's embryos look under the microscope or how the eggs look and get some more details so that, we can really individualize care and dive into each couple's unique situations. And they've been really wonderful as far as being open and being accessible and documenting everything so thoroughly. So I truly appreciate how awesome our embryology team is.
Yeah, I mean, they're for sure what's behind our success rates, for good or for bad. So it's we appreciate that.
Yeah, no, we're very lucky, and I think I've said this on a prior Facebook Live. We're very lucky to have the embryology staff that we have. they have to be obsessive compulsive. They have to cross every T and dot every I, and then double check that they crossed every T and dotted every I in order to make it work. If not, then everyone can tell immediately that something's wrong. And luckily you have to be a special kind of person to work in the embryology lab and to have the success that they have shown for us. And so we're very, very lucky to have them. I'm going to ask one more question to Dr. Goulet, because I know that this comes up sometimes too, and it's more of a clinical question. Somebody who has frozen embryos or frozen eggs, I oftentimes will get the question of, how long can they keep them stored? How long can they keep them frozen? Is there a shelf life? Is there going to be, freezer burn? Things, which obviously doesn't happen, but sometimes I'll get that question. What's your response?
Right now, the oldest embryo that has been transferred, stored in cryopreservation, and turned into a beautiful baby, the record right now is 27 years. So granted, technology 27 years ago, as Pauline had referenced earlier, was different. We were doing slow freeze back then, and now it's vitrification. And so not all labs still have the equipment and the technologists who were experienced back in the day in the old technology to thaw these embryos and transfer them. But we're really fortunate here that we do have such an experienced team. We are seeing fewer and fewer slow embryos, or fewer and fewer of the slow freeze embryos around, because most of them have been used up by now. But yeah, 27 years. So the thought is that these embryos are good indefinitely in cryopreservation, that they are very happy in that liquid nitrogen, and we can come back in a month, in a year, in 10 years, or 100 years, and those embryos would still be just as effective and good.
We'll all be dead by then, but yes, the embryos will be fine. There are a couple last questions here. So we have a question: how do you know if the sperm is the problem or egg quality is the issue if the embryo does not develop to the blastocyst stage? That's a great question. It really is sometimes something that we don't know for sure, but oftentimes we can make assumptions based on the patients themselves. So if it's somebody that we know has poor egg quality initially based on markers of ovarian reserve, based on female age, then oftentimes we'll kind of sort of assume that it is an egg quality issue. Similarly, if we know that if there's a male factor problem that we know about ahead of time, oftentimes we might blame the sperm. There are some additional testing that can be done for both male and female. In particular, there's something looking at sperm DNA fragmentation, which can give us additional information if the semen analysis is normal, which can give us some information about that. And there are also some characteristics in the lab. For example, if the fertilization rate is very poor, then sometimes we might kind of blame, I hate using the word blame, but I'm just going to use it. Then we might blame the sperm. If the embryos kind of stop growing at that day 3 stage, oftentimes we might say that that's also a sperm issue, and everything else we say is an egg issue. It's usually an egg issue, but unfortunately, there are some characteristics that we look at that we might say sperm. And then the most important thing to remember is that infertility is usually a combination of factors. It is, even when we don't know it is a combination of factors, it is a combination of factors. Okay, even when we think it's one thing, oftentimes down the road, we're like, whoa, there is a lot of other stuff happening here. And so many times it's just, egg plus sperm issues that are the problem here. And then Dr. Fratarelli, maybe you want to answer the last question posted there about how you pick amazing embryologists.
Well, I think we get lucky getting the amazing embryologists. But I think the question also states that our embryologists have won several awards, and how do they get those awards? How is that chosen? It's not something that we choose. Obviously, we would choose them all, but we have. There's a national egg bank that we belong to, and with that national egg bank, they look at all of the centers that freeze eggs and thaw eggs, which there are I think 50 to 60 centers across the country that are involved now. and they keep statistics on specific, embryos or eggs that the embryologists are freezing and then thawing, the percent that survive, the percent that will fertilize, the percent that make blastocyst embryos, the percent that actually cause a pregnancy and cause a live birth. And they keep all of these stats, and they keep them on all of the embryologists that are involved. And once a year, they start, they start teasing that out, and then they give out awards for the embryologists that have the best success rates. And we've been very lucky that our lab has done very well over the last several years. The reason they do that is not necessarily to give out awards. It's to make sure that if somebody's lagging behind, that they then can look and go to that program and say, what's happening here? And the reality is, it's not always the embryo. It's not the embryologist a lot of times. It might be something wrong with the equipment. The heat stage is wrong, or maybe it's something else in the lab. It's the media or something else. And so but anytime they see something that's a little bit off, then that alerts us to start looking and seeing what other issues there could be, and trying to delve in and try to find the problem, because we all want the same thing. We all want success for our patients, and so while the awards are great, it's really the success for the patients that everyone really cares about.
Yeah. All right. Well, thank you so much, everyone, for joining us. I hope you learned a lot about a field which is usually very much behind the scenes, and Pauline rarely sees the light of day, from what I hear.
There's a lot of foundation on to get the color to look.
All right, guys, thank you so much for joining us. Join us next time for our next Facebook Live session. I'm sure that'll be just as interesting. Okay.
Thanks, guys.
Thanks for having me.
Bye.
Bye.